Someshwar Garu, we can go live now. You can start. Dr. Someshwar.
Ma'am, with your permission, shall I start?
Dr. Someshwar, now we can start.
Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you for today's webinar on PCOS holistic approach. In this pleasant evening, we are here with Dr. Pranabika Mahanta, madam. We are very honored and grateful to have you for today's webinar. And I request all the participants, please do post your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now Dr. Pranabika Mahanta, ma'am, she is an assistant professor in Ops and Gynecology at JMCH College and Deputy Superintendent for JMCH. And she is a resource faculty of MCA Regional Center for Faculty Development and Zorahat Medical College, Assam. And with this, we welcome you for today's webinar, ma'am. And the present webinar is streamed through Shield Connect, which is a digital platform to connect all the doctors at one place. And we have a blogs page, and also we have a webinar where you can find all the webinars which are search to the topic. And we have an awareness page regarding the immune boosters, PCOS awareness, COVID, and all kind of awareness. We have our leaders page who supporting this digital initiative. With this, I conclude my introduction. And coming to the today's topic, as we know that PCOS is a complex disorder that can be managed but not permanently cured. Each woman has her own PCOS symptoms and its own root causes. A number of medications are prescribed to manage presentation. Yeah, well, you can start. Ma'am, actually you're on mute.
Can you hear me now?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Yes, ma'am, I can hear you now.
Yes, ma'am. Yes, ma'am.
Okay, good evening to all of you out there, ladies and gentlemen. So today my topic of discussion is PCOS holistic approach. So here we'll be talking about the background, definitions, prevalence, issues related with PCOD and approach in the management of PCOD. So if we start with the background, it was a disease or syndrome described by Saint and Leventon in 1935. In 80s and 19, when ultrasound was introduced as a diagnostic tool, then ultrasound criteria were also laid down. in 2003, Rotterdam Consensus Conference has come out and they have given us the Rotterdam criteria. In 2018, International Evidence-Based Guideline for the Assessment and Management of PCOD Syndrome 2018 has come up.
I'm sorry to interrupt.
Yeah. Hello?
Yeah, ma'am, we can't see your slides.
You cannot see my slides. Okay.
Yes, yes.
Wait. Just a minute.
Ma'am, please share the screen, ma'am. Share the screen.
That's right. Just a minute. I'm just finishing this. Okay, probably I have opened from somewhere else.
Ma'am, if you're not able to share the screen, so can I share the screen for you, ma'am?
Yeah, just a minute. I'm trying now. Again. Now, can you see me? See my slide? Hello?
Yes, ma'am. Yes, ma'am.
Yes?
Yes, ma'am.
Okay,
Yes.
okay.
Yes, ma'am. Yes, ma'am.
Okay, I have opened from a different one. Now, is it clear?
Yes, ma'am.
Yes, ma'am.
Okay. So this background I have already talked about. Now coming to the introduction of PCOD, it's not merely a disease of reproductive disorder, but an endocrine disorder affecting women in their reproductive years. Although it has hyperandrogenism, infertility in that PCOS causes these are distressing to young women. And it has also certain metabolic sequelae, which eventually plug them into individual in terms of morbidity and mortality, especially type 2 diabetes mellitus. So PCOD, if we define it, it's an ovary containing more than 12 or more follicles, measuring 2 to 9 millimeter in diameter, or an ovary that has a volume of greater than 10 ml on ultrasound. And we also see the different echogenicity than the normal ovary. Then a single normal meeting, it may be in one ovary or both. So ultrasound should not be used for diagnosis of PCOD in those women who are less than 8 years, rather adolescent girls less than 8 years or less than 8 years after menarche, due to high incidence of multiple follicular development at this stage. Now coming to the clinical features, we have three main clinical features. One is gynecological, second is metabolic, and androgenic. We all know in the gynecological part, it is irregular menses and an ovulation causing infertility. Then metabolic, we have insulin resistance, obesity, increasing the chance of type 2 diabetes mellitus, acanthosis nigrans. And androgenic, we can see all the male pattern hair distribution, alopecia, hirsutism, and acne. So now we have three different criteria that has evolved over the years. And the most recent, we have Rotterdam criteria. We have National of Health, Institute of Health guideline, which was in 90s, 92, Androgen Access Society guideline. So out of this, if we see, we have three parameters: hyperandrogenism, biochemical and biochemical and oligoinvolution, and polycystic ovarian ovaries. So if we have hyperandrogenism, then an ovulation and polycystic ovary, all these things, or 2 out of 3, we consider them as PCOD according to the Rotterdam criteria. Now we have certain phenotypes according to the presence of or absence of this clinical 3 criteria. If we have all the 3 criteria present, that hyperandrogenism, ovarian dysfunction, and PCOD on ultrasound, polycystic ovaries on ultrasound, then we consider it as phenotype 1A. sorry, then if it has hyperandrogenism and an ovulation or oligoovulation, but it doesn't, ultrasound doesn't show a polycystic ovary, then it is phenotype B. If it has hyperandrogenism, polycystic ovary, but we don't have ovarian dysfunction, then it is phenotype C. And D is that we have ovarian dysfunction along with PCOS in ultrasound, but we do not have any hyperandrogenism symptom. Now we have many factors that are contributing to this PCOS phenotypes in utero. We can see CNS programming, many factors: environment, influence, exercise, hormonal exposure, ectopic fat, androgen excess, insulin insensitivity, many factors that contribute to the pathophysiology of PCOS. So basically, I'm not going to the details of this slide, but what I want to tell you is, when we say pathophysiology of PCOS, we have only two things to come up, like that disturbs the harmony of the hormones. That is, one is insulin resistance, and second one is your decrease that altered pulsatile secretion of the GnRH. So if we have two factors, main factors to lead that leads to hyperinsulinism, we can understand the disease. So there is, if the pulsatile secretion of GnRH is hampered, then the LH and FHH ratio is altered. Normally what happens that FSH is more and LH is less, and one time of the cycle when there is pulsatile secretion of the GnRH, then we get a high level of LH, which causes ovulation. But in PCOD, what happens is that LH goes above the normal level and FSH comes down. In normal, FSH is high, so follicles normally grows and LH surge is there. So in the LH surge, there is ovulation. But this is hampered in PCOD. Next is insulin resistance. What insulin resistance causes? It causes hyperandrogenism. Because insulins are increased, your body, there is retention of glucose in your body, you gain more of fat, excuse me, more fat, and yeah, there is hyperandrogenism. Excuse me. Okay. So development of insulin resistance, it controls LH levels, controls androgens, insulin resistance coexist. All these are leading to insulin resistance. Now, what does PCOD does? One is infertility, primary infertility that is reported in 50%, secondary in 25%, obstetrics, high incidence of preeclampsia, GDM, preterm deliveries, risk of IUCR, cardiovascular, there are increased chances of MI, excuse me, increased risk of hypertension, metabolic, there are increased risk of type 2 diabetes, oncological, there are increased risk of endometrial cancer. Excuse me. So long-term issues associated with PCOD. So we know genetics, lifestyle, hormonal changes, obesity exacerbate the hormonal changes. Everywhere, whenever there is obesity, there is this, the harmony of the hormones, that is the environment of the internal environment of the hormones disturbs. So hyperandrogenism causing hirsutism. Because of hirsutism, there can be psychological impact, decrease in the self-esteem, depression, anxiety, all those. Increase insulin, that is leading to ovarian follicle and ovulation. Menstrual disturbances, subfertility. Then high level of insulin, that is causing diabetes, cardiovascular risk, all those things. Ultimately, they are leading to some lifestyle problems. So PCODs and metabolic syndrome, excuse me. Prevalence of metabolic syndrome is very high, as high as 46% in PCOS cases. So these are because these are the risk factors which may lead to metabolic syndrome. That BMI is more than 30, HDL is less than 40, triglycerides are high, BP is high. So all this can occur in as a sequelae of PCOS. Insulin resistance, we consider that as the underlying pathophysiology, major pathophysiological factor in PCOS. Weight loss and lifestyle modification is the safest and simplest therapy. So existing data suggests that PCOD adversely affect or accelerate the risk of cardiovascular and atherosclerosis diseases. Obesity and infertility causes the greatest degree of stress to human life. Cardiovascular risk in PCOD, there are several studies which intimate the median thickness of all those stuff, all risks are increased with PCOS. Coronary arterial calcification is high with PCOS. Sleep apnea and other sleep disorders are more. PCOS lead to chronic anevolution, obesity, hyperinsulinism, hyperandrogenism. That results in bioavailability of unopposed estrogen. There is estrogen, but there is deficiency of progesterone. So all this leads to that normal ovulatory functions are hampered and normal endometrium is not maintained. So PCOS, women with PCOS has 2.5-fold increased risk of developing ovarian cancer and 2.5-fold increased risk of developing ovarian cancer. So PCOS and pregnancy, we can see multiple pregnancy with, because there are multifollicular developments more than miscarriages are more, pregnancy-induced hypertension and preeclampsia are seen more in PCOS patients. There is 2.4-fold increased risk of ZDM among PCOS women. ZDM comprises 40 to 50% of PCOS pregnancies. They have hypertensive disorder, as I have already told you. So there are common factors which increases risk for severity of COVID-19, and also there is increased incidence of metabolic risk for PCOS patients. They have a combined risk factors like obesity, hypertension, type 2 diabetes mellitus, metabolic syndrome, ethnic minority group. They have this high level of cytocrines, high level of androgens, and low level of vitamin D3. All this imposes the patient more to the risk of COVID-19 as well as PCOS. So main treatment plans, what we do, we need to restore the normal spontaneous menstrual cycle. We should try to reduce the androgen levels. We have to overcome insulin resistance, and also we have to improve the oocyte maturation and oocyte quality. The first line therapy is, everyone will agree that it's lifestyle modification and lifestyle modification. We have to decrease the weight of the patient. We have to change the diet. We have to increase physical activity. That decreases serum insulin level, androgen level, and risk factors. Here, I would like to emphasize more on that we need to burn whatever the PCOS patients need to burn, whatever energy they eat or whatever food they eat, they have to burn that. And they have to increase the heartbeat to a certain extent. During that workout session, they have to at least increase the heartbeat to more than 60 beats so that it can be burned. Their fat can be burned. So activity is like, it's not just activity, it should increase your heartbeat so that there is calorie burn in it. That we have to make our PCOS patient understand that. Next, managing the menstrual disorders. With low dose OC pills, we all know that is recommended, and there is a good result in PCOD cases. Then for hirsutism, we can have use spironolactones. We can have cyproterone acetate. This has been given a lot in PCOS cases, along with progesterone. It inhibits the testosterone production, resulting in 75% of decrease in the circulating testosterone level. Flutamide is there, finasteride is there. So these all drugs have been tried. PCOS. Excuse me. Then myoinositol at a dose of 4 gram dose in the powder formulation is very effective in hirsutism without any side effects. Though we need to give it for more, maybe 6 cycles like that, but yes, it responds. So if we see the broader aspect of treating PCOS cases, it is medical ovulation induction and surgical ovarian dealing. So first line treatment, ovulation induction can be done with promethazine citrate. Second line, we can go for gonadotropins, letrozole. Strong evidence confirms that efficacy of inositol in restoring fertility in PCOS patients better. Surgical, yes, there are a lot of controversies, but in some cases, fertility benefits we have seen with drilling, ovarian drilling. Then for ovulation induction in PCOS, we always start with clomiphene citrate. After 6 ovulation fails to yield a pregnancy, then we probably after we can go for the second line. Then if there is no ovulation with 150 milligram per day also, then we can switch over. And if there is less than 7 mm of endometrial thickness at the ovulation time, so we have to think about some other like aromatase inhibitors, letrozole. They don't block the estrogen receptor, so the endometrial thickness is not a matter for us. So this can be used. Anastrol is another one which is done. There are a lot of studies with this. So it will depend on individual, which like subject to subject, we can vary which one to use for ovulation induction. Next is metformin. It is recommended in presence of metabolic features, or also in cases where we have family history of type 2 diabetes and they have obese more than 25. Insulin sensitizing is it's a sensitizing agent, and we are using this with various success rates. Increase but with low frequency, lower conception rate per ovulation than other method, although so may improve response rate with clomiphene. With clomiphene citrate, it's a very good drug. Reduction of androgenic symptom is very much with this drug. So if we see insulin sensitizers, this lowers hyperinsulinemia. Insulin resistance is not seen in all patients. So right, left, if we go for insulin sensitizers, it is also not good. NCI disturbances are more with these drugs. Oral contraceptive, yes, it's combating the hyperinsulinism, and they will have the cyclical menses. But they don't restore ovulation. In fact, if we are giving Ocipil, it will cause an ovulation. So fertility issues are there. Ovulation induction drugs, yeah, it can induce ovulation, but everyone may not need ovulation induction. So, and if in PCOS cases we are giving ovulation induction drugs, there are chances that there can be ovarian hyperstimulation if we don't go for the right dose and the right person. Then anti-estrogen, yes, this lowers the hyperandrogenism. It's combating the hirsutism and virilism, but it doesn't tackle with the insulin resistance. So for each individual, we have to customize the treatment plan. So here we are not treating the symptoms, but we are treating the symptoms, but not the cause. So if someone is having hyperandrogenism, we are targeting like that. So insulin sensitizers, we are giving this ovulation ovulation induction, we are giving for cyclical menstrual cycle, we are giving Ocipils. Cosmetic, we are going for results, but we are not actually doing what we can just help the patient by treating her symptoms. So root cause of developing PCOS in women due to reduced or altered level of myoinositol in the ovary. So it is a factor that is causing an ovulation in the ovary. So if we see there is imbalance in the LH and FSH ratio, that reduces the aromatase activity, and that can be increased with myoinositol. So that there will be steroidogenic modulation. So this can be tackled with myoinositol, and insulin resistance is well tackled with dichloroinositol and myoinositol, and that will upregulate this, and there will be secretion of CNH pulses, and there is downregulation. So all this can be dealt with myoinositol or dichloroinositol. So increased androgen production can be decreased with this. So it's a circle. It's that whole biochemical things can be modulated with myoinositol and dichloroinositol in the right dose. So current treatment paradigm is that metformin is okay. We are using insulin insulin sensitizer. All these are effective. Then 2017, the myoinositol has come. Both have preventive effect on GDM and also PCOS. And so is metformin. It is safer than metformin, and it doesn't have so much of side effect. Also, could inositol be considered to treat PCOS? Yes. So it is commonly found in fruits, grapefruits, and highest vegetables, and in all foods containing seeds like beans, almonds, and walnuts, the highest. It plays an important role in the secretory messenger in the human this multiple functions. So enzymes, these are triggers, and ultimately there is cellular response through the cell membrane it crosses, and there is cellular response which changes the hormonal milieu. Myoinositol is present in high concentration in the ovarian follicular fluid. It's essential for normal reproductive function of the female body. High level of this in the follicular fluid is very important for follicular growth and oocyte maturation. High level of this ensures the quality oocyte in the ovary. So it corrects the LH and FSH ratio by regulating ZNRH pulsatility, improves insulin sensitivity by acting as a secondary messenger for insulin action in the peripheral tissue. It brings down the plasma levels of insulin. It improves ovulation and oocyte quality by acting as a secondary messenger for FSH. Restores ovarian cycle faster. 88 patients restored spontaneous menstruation. It has been reported in the Gynecological Endocrinology 2017. 72% maintained a normal ovulatory activity during the follow-up period. More than 30% of the patient establishes normal ovarian rhythm throughout this period. 73% there is reduction in testosterone level, which will be dealing with the hirsutism and acne. 92% increases the sex hormone binding globulin. 65% reduction in high insulin level. Now, going through the clinical evidence of myoinositol, there are many papers, more than 39,000 papers published in up to 2014. So evidence is saying that this is one study where we have two groups. One is with myoinositol, another group is with folic acid and placebo. They have continued the treatment for 12 weeks, and there is a decrease in both insulin and BMI. Has been reported in this study with the myoinositol group, and there is reduction after 12 weeks of myoinositol in administration. Insulin sensitivity and HOMA index is significantly improved. There is 56% reduction there in the HOMA index. What is HOMA index? It is the homeostasis model assessment here of insulin resistance. The level of glucose is measured and serum insulin is measured, that is multiplied by, and then it is divided in 405. Normal index would be less than 3. And if it is more than 2.5, it is considered a reasonable indicator for insulin resistance. Next, all those research have on myoinositol, they have said that the insulin sensitivity is expressed as glucose to insulin ratio, and HOMA index resulted in significant improvement after 12 weeks of treatment. So menstrual cyclicity was restored in all amenorrheic and oligomeric subsets. This study also said myoinositol and these levels have decreased in the used group. Myoinositol gives 65% reduction in testosterone level. 69% patient ovulated with myoinositol acid. 40% pregnancies with myoinositol and 90% pregnancies with fetal heartbeat. This is a very good outcome report. Myoinositol offers better clinical pregnancy rate and delivery as compared to placebo in PCOS. Myoinositol shows significant improvement in metabolic characteristics like baseline BP, triglyceride, cholesterol. It's a novel method for ovulation induction. They have in this study they have established that myoinositol is a simple and safe treatment that is capable of restoring spontaneous ovarian activity and consequently fertility in most patients with PCOS. This therapy did not cause multiple pregnancy. So if we see the algorithm in PCOD and ovulation induction, Rotterdam criteria we follow. Then ovulation, if ovulation is there in the Rotterdam criteria, then yes, we can wait for normal cycle for conception. If there is no ovulation, then we go for full fertility investigation assessment insulin resistant, overweight, we have to go for lifestyle management and bariatric surgery and all. Then ovulation, if after weight reduction there is ovulation, then again we can ask them to go for natural cycles for conception. Then if there is no ovulation after lifestyle modification, then we can proceed with CC, fencytrid or letrozole. If there is ovulation, then it's okay, we can go for cyclic LDs. If there is for natural cycle conception, if there is no ovulation, then we will probably have to go for CC with metformin or gonadotropin or laparoscopic ovarian drilling. And if there is ovulation detection is there, then probably we'll allow her for normal. Or if there is no failure of the second line therapy, this treatment, then we have to go for IVF with GnRH antagonist protocol. So mostly in IVF centers, probably they are doing GnRH antagonist protocol for PCOS patient, and they have come up with good results. Effects of insulin in IVF cycles. So at the end of the treatment, we go for the follicle diameter 15. Then they go for number of oocytes recovered. They go for pickup and found that significantly greater in the myoinositol group than the other groups. So myoinositol, that also improves the oocyte quality and maturation. It plays a key role in nuclear and cytoplasmic oocyte development. Higher concentration of myoinositol in the follicular fluid is a marker of good quality oocyte. In IVF programs, it improves both the quality and number of mature oocytes, significantly reduces the number of immature oocytes, reduces the chance of OHS in IVF cycles. Then side effects. So it is well tolerated and safe both in obese and PCOS, lean PCOD patients. There is not only safe in pregnancy, but beneficial. We can continue in pregnancy also, so that it doesn't develop the complications of PCOD. Side effects when the present are mild, very mild, and maybe gastrointestinal side effect, nausea sometimes. It reduces the chance of neural tube defect also additionally, and it improves their gestational diabetes mellitus, or it prevents rather. Then its supplement is a simple and safe step in the treatment of gestational diabetes. It takes the total care of symptoms. It acts on the insulin resistance also. It decreases the insulin resistance. It improves its sensitivity. It reduces free testosterone level, restores the maturation and normal ovulation by working on the ovary itself. Then it improves pregnancy rate. It improves glucose utilization, and all that. That's what it causes reduction in weight also. That is how. So coming to the end of it, the take-home message is it's a comprehensive management of PCOD requires a patient-centered approach. We have to know that which patient to be treated with which molecule. Then, and lifestyle, yes, hyperandrogenism, hyperinsulinemia can be looked after this every PCOD. Significant time dedicated to thorough education and counseling, especially for lifestyle modification, because lifestyle modification is the thing. Even if you are treating with any molecule, without lifestyle modification, there can be problem with it. So as a first line treatment, we have to counsel the patients that yes, your weight is causing the problem, and we have to make them understand that the fat underneath your skin is the cause of excess of estrogen in your body. So the way it should be counseled, that they can accept it and they can be motivated with our counseling for a lifestyle change and loss of weight. So ovulation inducing agents and adjuvant can be customized. We know, as I have already said, that if a patient has come to us for infertility, then we have to go for ovulation induction drug. If the patient has come for just for regular cycles, then we can go for ocipils. Or if she is an adolescent, we have to go for myoinositol and this in the first line, because all these things are important, that we as physician, we as doctor, we should get what the patient need, and we have to customize it. Then for cycle cancellation rate and OHH risk are higher in IVF cycles, so we have to be very much cautious in ovulation induction of these patients. And do it the way the protocol says for IVF center. Every center must have some protocol for IVF in this PCOS patients. So we have to be overcautious for this PCOS patients. Treating physicians should be aware of difficulties and remedial solutions of for this PCOS. So to conclude that, P stands for prepare and assist the woman with the necessary information and resources needed to get them tested, then communicate informations to the public and to women diagnosed with PCOS, because it has now so prevalent in our part that every second, third lady is coming up with PCOS. So we have to communicate them about the root cause of PCOS and the treatment modalities that has overcome. Assist the woman in diagnose the PCOS to overcome their symptom and lessen related health risk, and provide support as a support that network to freely and openly discuss all the aspects of PCOS. Thank you.
Thank you, ma'am.
Madam, thank you, ma'am. Manav.
Yeah, Manav.
Dr. Someshwar, any questions we have?
Yeah, we have one question. Yeah. Is there any role of AMH in PCOS? Hello?
Yeah, AMH. Okay, usually it is high because we have those individuals who are in PCOS now, though we are starting from adolescent only, we are getting. So definitely like for ovulation induction, doing ovulation induction with high AMH, we have to be cautious. That is one I can say. But yeah, AMH very rarely we get less than 2 in PCOS cases.
Yeah, thank you, ma'am. Ma'am, no more questions from the delegates. So if you allow me, then we will close the webinar. Hello.
Someshwar garu, is there any other question?
No more questions.
Okay. So
Okay.
Yeah, thank you very much, ma'am, for your wonderful talk. And
Thank you.
we are very honored and learning to hear you, ma'am. And we look forward for your continuous support for upcoming educational activities as well. Thank you very much, ma'am. Many
Sure.
thanks to the team. I also thank all the delegates who are participating in this webinar. Thank you, ma'am. Thank you, Savan, and thank you, Manav and Karnakar.